Thank you. Good afternoon, everybody. Welcome. This is the CHPR seminar series. For some of you, this is EPI 291. For others of you, this is a chance to get continuing medical education credit. We have with us Dr. Lyles, the center's director. We have with us Dr. Amanda Midboe. She's our speaker for today. Dr. Midboe is a professor in the Division of Health Policy and Management in the Department of Public Health Sciences at UC Davis. She also has other affiliations that she will tell you about. She is an expert in implementation science. She will be able to explain what that means. People who do that are very, very important. They help us understand how to use the stuff we should be using already. Dr. Midboe will tell you a bit more about her career as well as she goes through this. Dr. Midboe, would you like questions at the end of your talk or during your talk?
I think we'll just have folks put them in the chat, and then if you don't want to put it in the chat, we'll just do it at the end, since I fear I may not be able to easily see if someone raises their hand. Usually I like
Super,
it during.
super, super, super. So the three objectives for Dr. Midboe's talk today are: one, to learn about key facilitators and barriers for implementation of opioid overdose education and naloxone distribution for homeless experienced individuals; two, to identify implementation strategies that facilitate implementation of OEND, that's the opioid overdose education and naloxone distribution; and three, application of implementation theories, models, and frameworks. Dr. Midboe, thank you so much for joining us today.
Wow, I shouldn't have put those learning objectives in my slide. You're welcome. Thank you so much. I'm excited to talk with you all today about implementation of overdose education and naloxone distribution in a permanent supportive housing program. As Dr. Hotch noted, I'm in the Division of Health Policy and Management as an associate adjunct professor. But today I'm going to be talking to you about a project I did in my other role. I am a core investigator at the VA Palo Alto Healthcare System Center for Innovation to Implementation, which is a research center. And everything I've done that I'm covering today was done in the VA healthcare system. Oh, oops. Let me make sure I can easily, there you go. So as a result of being in the VA, I have to put out this disclaimer that we always have to put out, which is the views expressed in this presentation are mine and do not necessarily reflect the position or policy of the Department of Veteran Affairs or the US government. And these are the learning objectives that Dr. Hodge just covered, so I won't repeat them. And I'll get into what I'll be covering today. So first, I'm going to set some rationale and provide you some relevant background because I don't want to assume everyone comes into this understanding why harm reduction or OEND is important. And then I'll end with just describing the aims for the implementation trial I did. And then I'll launch into describing our multi-phase formative evaluation, as well as how it informed our implementation approach, and then cover some preliminary findings and describe where we're going in my team with the next steps. All right. So probably everyone knows we've been in the throes for quite a while of an opioid epidemic. And when we were starting this implementation trial, the US was seeing an increase in overdose deaths with a peak around mid-2023, with predicted deaths from drug overdoses over 110,000. Now we're seeing a significant decrease, returning to 2021 levels. We started to see that downturn in 2024 with updated data last year, and now we have data updated through January of 2026, and that downturn is continuing. I mean, we're still at an unacceptable level of overdose deaths, so it's important to continue our harm reduction efforts. And just to break this down a little further, particularly for those who don't have a background in this, there's this lovely dashboard on the CDC website that lets you select different categories of types of drugs related to the drug overdose deaths. And I do want to note that, if an individual had a drug overdose death from opioids and cocaine, they'll appear in both categories or on these lines together. So these aren't mutually exclusive. And as you can see from this, drug overdose deaths are primarily driven by opioids. So the black line is all opioids, including those used for pain, such as oxycodone, hydromorphone, whether prescribed or not, heroin, and synthetic opioids like fentanyl, methadone, tramadol. I highlight both the cocaine-involved overdose deaths in the pink line and other stimulant-involved overdose deaths in the gray line because those taking stimulants, particularly cocaine and methamphetamines, are also at increased risk for an opioid overdose for a couple of reasons. One is some users of these drugs find it more pleasurable to combine the opioids and stimulants. Also, there has been a significant increase in recent years in cross-contamination or adulteration of fentanyl into cocaine and meth. So users of stimulants are being exposed to the incredibly potent opioid fentanyl without even knowing it. So to highlight some other rationale around stimulants, because even some clinicians still don't know that their patient may be at risk for an opioid overdose because they're using stimulants. I just want to provide a little more background and some research to look at. So two papers. This first one, they took samples of drugs that were sent voluntarily from 77 harm reduction programs and clinics across 25 US states and tested them. And they found that 12 to 15% of powder meth and cocaine samples contained fentanyl. Heroin was also found in unregulated stimulants. And there's just a lot of research out there, but these are a few or two recent ones. This also is an interesting rapid ethnography study to evaluate motives for co-use of opioids and methamphetamines among people who injected heroin and fentanyl and meth. They had a sample size of 30. And the reasons for combined use was it's more pleasurable than separate use of each drug type, sometimes known as speedballing or goofballing. I believe speedballing is cocaine and opioids, and goofballing is meth and opioids. And the idea is you get this euphoric high from the stimulant and then this calming effect from the sedating effects of the opioids. There's unfortunately also the mistaken belief from these users that methamphetamine can prevent or reverse an opioid overdose. And then lastly, when both drugs are in high supply and easy to get, those using in their area who have, they're participating and having shared drug use, they just start to use them because others are using them. There's a lot more to dig into here, but I just wanted to really highlight because many people don't understand the risk of stimulant use for opioid overdose risk. So I wanted to spend a little time on that today. And lastly, many of you, maybe you know, maybe you don't, but homeless experienced individuals have an increased risk of opioid overdose. One recent study showed that individuals who are homeless are at increased risk for opioid overdose compared to low-income housed individuals. There was also a recent cohort study that showed 1 in 4 deaths among homeless experienced individuals involved synthetic opioids and polysubstance use. And then lastly, a paper published last year shows that veterans seen in VA homeless programs, where again, this work was done, have an elevated risk of overdose, particularly related to opioids and psychostimulants. So with that background, I'm going to get into the intervention that I implemented, the highly evidence-based intervention known as overdose education and naloxone distribution. And I like to divide it into two components, overdose education and naloxone distribution, because particularly in the VA where it requires a prescription to give naloxone, you can really break this out into a team where one person who is not a prescriber can be responsible for the overdose education and the prescriber can be responsible for naloxone. So what does overdose education involve? It involves alerting an individual that they're at risk and why they're at risk. Are they taking stimulants, opioids, tapering a prescribed opioid? And I'll get to who should get offered naloxone in a little bit. You also want to cover the signs and symptoms of an opioid overdose. So if they're seeing someone, they can recognize, oh, I think this might be an overdose. Or they can, if they're the individual who needs a naloxone, they can inform others about signs and symptoms of an opioid overdose. And it also involves telling the individual that there's a safe and effective medication to treat a possible overdose, which is most commonly now the nasal spray pictured here, how to use a naloxone, and what procedures they follow in the event of an overdose. And there's a few steps. It's not just spray and they're done inside their nose. You need to monitor them for signs of recovery or getting worse, and you want to call 911 regardless of whether you think it's effective or not, and consider using a second dose. And how to safely store naloxone. So many individuals don't know if, let's say you're in Sacramento in the summer and you're living out of your car, if you leave it in your car glove compartment, it will overheat and lose its effectiveness. So if you're storing it in a high heat environment, it's not going to be as effective. So educating the individual about how to safely store it. And ideally, there's a buddy of the at-risk individual there for all of this overdose education, but that is so hard to have happen. So it should never be a barrier to getting overdose education and getting naloxone in their hands. It's just sometimes you provide additional education material they give to a buddy later. But ideally, you want someone who can save the individual present for the overdose education. And then lastly, there's the naloxone distribution, which when I started this trial was not available over the counter, but became available over the counter. Naloxone's amazing. It's incredibly safe. It's super effective in block, when it's in its high potency and stored safely. It blocks opioid receptors and potentially reverses an opioid overdose. Again, when used with the correct procedures. And still to this day, veterans seen in VA can only get naloxone from the VA by getting a prescription. The good news is it's free. So anyone who's homeless experienced just gets it for free. They can get it replaced if they lose it, get it for free, and it's just wonderful. It is now available over the counter, and I've seen it just in Target and the regular, pharmacy aisle. That not, you don't have to go to the pharmacist, it's just on the shelves. So it's about $44. Everyone can get it. And it's been available. It took a little while to get widely available when it became available over the counter. But because it costs $44, it's still not ideal for homeless individuals to have to pay that money for over the counter. And there's a lot of ways you might be able to get it free from the community. Okay, so who is at risk for an overdose? As you know, I harped on how people with stimulant use do have a risk for opioid overdose. And this lovely infographic, it is from VA's Pharmacy Benefits Management, or PBM for short, but I love it because it's just so succinct and beautiful. So anyone who's prescribed opioids should be offered naloxone or get OEND. That includes asking, okay, if you're in the VA, do you have any prescription opioids outside? Not just assuming you know based on the electronic health record. If an individual is being tapered off their opioids, so they're being deprescribed, that means they're losing their tolerance to the original dose. So they're at risk if they say, my pain is terrible, I'm just going to go back to what was working for me. They're at risk for an overdose. They don't know that their body can't take it anymore. Individuals who have an opioid use disorder or who are using illicit non-prescribed substances should be offered naloxone. After an overdose, you want to make sure that individual has their naloxone overdose education naloxone. And individuals who are at a higher suicide risk. Many don't also know that individuals unfortunately choose opioids as a way to commit suicide. So being mindful and thoughtful about OEND for individuals at higher suicide risk is also important. Okay, so now let's pivot to why did I end up doing this work? I do a lot of work that addresses the opioid epidemic, but most of my work to date had been on helping implement clinics reducing risky opioid prescribing practices while increasing access to safe and effective pain management interventions. It could be non-pharm, it could be pharmacological, but making sure they get on the right course to get off of unsafe opioid prescriptions. And by get off, that doesn't mean they always completely get off an opioid, but they may taper down to a safer level. But we ended up having this opportunity to do this small supplemental grant associated with our larger center in implementation science several years ago. And we took it because we were really interested in examining the opioid epidemic in veterans who were homeless or unstably housed across the VA. And now this paper is just getting so old, it's 7 years old now. Uh, and we looked at a variety of metrics related to the opioid epidemic, including like how many morphine equivalents were these veterans receiving on average? Were they getting medication for opioid use disorder? But we also looked at whether those who should be getting OEND or getting naloxone were getting it. Sadly, what we found was that approximately 77% of veterans in all of the VA homeless programs, which is a lot, and who were at risk for an opioid overdose did not receive naloxone in the past year. And that is what eventually started my interest in doing an implementation trial in this clinical context with this intervention. With that said, there are a lot of homeless programs in the VA, and it was a little challenging to figure out, well, where do we test this implementation as we're planning for the grant, et cetera. And we decided to implement in the HUD-VASH program, which stands for Housing and Urban Development, VA Supportive Housing. Outside the VA, it's HUD, that it's known as. And there were quite a few reasons for it. Number one was 81% of veterans seen within HUD-VASH from our paper and who were at risk from an opioid overdose had not received naloxone in the past year, so a little above the overall average. It is also a very large program. It's the largest permanent supportive housing program in the VA. It's housed within the VA versus outside. So we knew we could reach a lot of veterans by doing a trial in that setting. Other programs that we considered that serve a large number of veterans were programs like supportive services for veterans' families, but they are not based in VA, which introduced a lot of challenges. So we had no way of easily identifying who are the eligible individuals, like from an electronic health record, who should be getting naloxone. We also couldn't track who was receiving naloxone unless we were going to put a heavy data burden on those individual organizations. There were also potential policy and legal concerns because it varies by state, a variety of things that affect harm reduction in OEND, and whether or not each nonprofit was allowed to do this, and they had the right staffing. And then there's just a lot of variation in internal structure for these non-VA nonprofit programs. So it was going to be very hard to design an implementation strategy approach that would work across multiple settings. So we chose HUD-VASH. Okay, and these are were our aims. So nothing really surprising here if you're an implementation scientist. So we wanted to identify barriers and enablers or facilitators to adopting OEND and HUD-VASH and then tailor our implementation approach across the sites. And we conducted what are known as formative evaluations at 3 phases: pre-implementation, implementation, and sustainment. And we use that to really, the pre-implementation, to really tailor our selected implementation strategies as we approached and began implementation with a site. Then we wanted to evaluate the implementation of OEND and HUD-VASH. We plan to use a hybrid type 3 cluster randomized step wedge design, moving from a lower intensity strategy to a higher intensity strategy. And again, through that tailored approach. And we use an incredibly popular evaluation framework known as REAIM to evaluate reach, effectiveness, adoption, implementation, and maintenance of OEND in those settings. And then finally, our last aim was really around ensuring sustainment. So when we left, how can we ensure that they're going to keep this going? So that involved ongoing program planning and stakeholder engagement with various partners, as well as those at the site level, and led to the development of an implementation playbook, which a blueprint or a plan, those are often products of trials, but no one really tests them, which I'm going to circle back to. So moving forward to the formative evaluation, I want you to bear with me here because I'm going to start to deep dive into some implementation science terminology. But we use I wanted to, excuse me, just one sip of water. For our formative evaluation, we were guided by the Dynamic Sustainability Framework, or DSF for short. And then we also relied on the Consolidated Framework for Implementation Research, or CFR for short, to define certain constructs. And that came later, but we realized there were a lot of fuzzy constructs in the DSF that really needed some clarification that CFR offered, which CFR is probably the most widely used determinant framework out there. And I'll talk a little bit more about that. But essentially, the authors of the DSF, they assert that a given practice, so an intervention like OEND, its maximal benefit can only be realized through ongoing development, evaluation, and refinement in diverse populations and systems. So by exploring contextual factors across different care settings, even different HUD-VASH clinic settings, you can explore the optimal fit of a given practice. So to improve sustainability, practices need to be integrated into ongoing care processes within the practice setting. And the ecological system, the teal layer there, interacts dynamically with the intervention and the practice setting and really impacts sustainability practice. And this is just like a very high level kind of jargony description of DSF. And then I'm going to deep dive a little bit more into some of the other pieces of it. But next, and you don't have to read this whole thing. There's some key takeaways here that I'll highlight. We have published our formative evaluation findings in implementation science communication, and this table is from there. But because one of our learning objectives is to think about how do we apply these implementation theories, models, and frameworks to the real world, I wanted to highlight this table that also highlights that we started with what we thought was a really great framework, the DSF. And then as we progressed, particularly into the analysis phase, we realized there was just a lot of fuzzy concepts and constructs we had yet to define. And I personally really like using CPR. Not everyone does. I am a clinical health psychologist by training, and this is a meta-theoretical determinate framework that integrates health behavior change theories and other kinds of things. So I find it really intuitive based on my training. Not everyone will, so not everyone will love CPR. But as you can see in the left-hand column, not sure if you see this, you have the domain, and then you have their identified constructs. And then you can see these red circles aren't meant for you to just like read every time, but you see how many times we had to invoke CPR to help define the construct. And I actually, the first author of the DSF, David Chambers, I actually checked in with him and I was like, I have to apply CPR because I don't understand your constructs always. And there's not enough detail. And CPR also has a wiki. It has all this information that helps you break down and use their constructs. And David just said, sure, go ahead. That makes sense. Anyway, so this is an illustration of how sometimes you need to get flexible if you find the initial framework isn't working for you in your given project. Okay, so let's deep dive into what we did for our formative evaluation. This is the only time I've ever been able to do a formative evaluation that's pre-implementation, implementation, or is at that phase of implementation, then at sustainment in the 6 months post-implementation. I'm hoping this will happen again in another project. But we learned so much by being able to do a multi-phase formative evaluation across 4 sites. So we collected, it was all qualitative. We had planned to do mixed methods, but to reduce participant burden, we were able to just incorporate all the measures into the qualitative work. And as you can see, the red is the pre-implementation phase, and the top you'll see when we recruited, the top row, I mean, and the data collection then happened. And then we had the active implementation is the blue. And you'll see when we recruited and collected data. And then for the sustainment, the teal, you'll see we were about 6 months post-implementation when we were able to collect data there. And this implementation was done in 3 phases with 2 sites for each phase. So A and B were implemented in roughly the same time frame in 2022. And then phase 2 was sites C and D in roughly the same time frame at the end of 2022 into the beginning of 2023. Hopefully this helps everyone understand. But just mostly for recruitment and data collection, you'll just pay attention here and to the top row and then the bottom. But you can see it was relatively staggered equivalently across these sites. And just for a high level overview, we relied on semi-structured interview guides guided by the DSF. We pilot tested the interview guide with 2 individuals, which you should always do. Highly recommend that. And we purposely sampled HUD-VASH leadership at a site. The social workers, all case managers at the sites we worked with were social workers. And we also interviewed prescribers who were pharmacists and physicians. And we had a trained interviewer and a note taker and the note taker completed a summary note template, which the interviewer also reviewed and checked and added notes to. And everything was recorded and transcribed using Microsoft Teams, which we've had a lot of success with, although you do usually want to clean up the transcript shortly after you do the interview. We were able to recruit a total of 67 participants across 4 implementation sites in 3 phases. I do have a parking lot slide, and it's also in the paper if you want to see how many across each phase and by site. And the reference for our paper is below. It's the Amanda Midboe one from 2025, if you want to look that up. And our analytic approach was a rapid directed content analysis using the DSF and CPR as a guide. We also followed best practices for rapid qualitative analysis in the PARCA, which is now, it came out in 2024, but we were following it. I'm one of the authors, so we were able to do these rigorous rapid qualitative approaches. All right, this slide is a lot. I'm going to break it down for you. So why I like this slide is because it's really rich and it's an interesting idea for anyone who does work in this area. First, what I will say before I go to the next slide that sort of starts to break this down for you is that this was not a figure we came up with on our own. When we submitted, a reviewer said, we think you should maybe describe how the determinants changed over your 3 phases of data collection, which at that moment I was like, shoot, why did we try to collect data across 3 phases? Because now we have to explain how the determinants changed. No, not really. But there was oh, I haven't ever done that because I've never done a multi-phase formative evaluation. So Sarah Javier, the co-first author on this paper, is really good from a graphics design perspective. And so she was able to come up with this. I will note in the paper this left-handed column, we made it grayscale, but even from the paper, it's grainy for the text. So I am using our original figures. But if go to the next slide, I'm going to start to break it down a little for you because it is overwhelming. So on this left-sided column, you see that it's basically the major determinant topic issue raised at the DSF level. And you can see that pretty egg yolk that has like a dark red, a blue, and a teal. And those map onto where does this determinant fit in the DSF levels? And essentially, these were the six major determinants we anchored on, looking at across pre-implementation, implementation, and sustainment. And the reviewer, this is why sometimes reviewers are just so great at making it work better, but they wanted us to identify if it kind of stayed bad. Did it stay misaligned, your determinant? Was it a poor fit? Did it get to a moderate fit or a better fit? They didn't quite get to these categories, but they wanted to know the fit, and these were the three that we came up with. And as you can see, burgundy is really the poor fit, the mustard is moderate fit, or pea soup color, and the teal is a better fit. And so just to illustrate, one of the determinants and it will come up later when I talk about some of the work we did, is a key determinant was that every site was very worried that OEND was outside the social worker's scope of practice. So that was a context specific at the DSF level of context. And at one site in particular, site B, which I showed in the previous table, social workers were so concerned that they would lose their license. They contacted the state board, and the state board told them to not do this, even though there's some debate about federal supremacy versus state supremacy and licenses, which is a long story in the VA. But what happened was I had to meet with that state's board of social work and to ensure that what we were doing in the VA as part of this implementation trial were in alignment with their vision and ensure that they did not think the social worker was going outside their scope of practice. So fortunately, it all worked out. So you can see it went to better fit. Like nothing is ever an ideal fit. But you can see how we summarize this over time. So they worry it's not part of their practice. Most of the concerns are mitigated by meeting with the state licensing boards or having their leadership reassure them. And so they're all really resolved. And there really hasn't been any other pushback ever from those sites. But that was a big barrier at first. But I don't know, I welcome feedback on this model. So now that I've gone into the weeds, I'll do some illustrative quotes that I think kind of represent what we were hearing from sites. So one social work noted really the importance of OEND and HUD-VASH. They said, as someone who's boots on the ground in the community with our most vulnerable veterans, I do think that there is a lot of stuff in our giant bureaucratic system that I'll be honest is kind of a waste of time. I feel like this is the complete opposite or completely the opposite. I think it's really important and I'm really excited that there has been this push to do this, which is always music to my ears as someone leading a trial. One supervisor noticed openness to OEND, noting, I was expecting some staff to maybe say, like, we already have so much to do, like we have to do this too, which is, I think, everyone who leads an implementation trial hears. And then they finished with saying, because at any given time, we're asking them to do many different things in many different programs, but they really didn't. They really embraced it. And what I learned a lot, having not worked also in a homeless program setting yet, so two things, I decided to work in OEND and in a homeless program setting. And what I learned is that because of, particularly then and still now, there's a very huge focus on housing first and connecting the veterans to service, and they don't think much about harm reduction, which shocked me. That was one of the biggest surprises of this implementation trial. Fortunately, they were very open to it. And then just a couple more things. Some barriers to ongoing progress were noted by two different supervisors. One noted there always seems to be about 5 million things that we need to do, and sometimes getting that eligible patient list pulled and getting it out has not been the priority. So one thing we had to do as part of the implementation is make sure they knew who was eligible. So there's a dashboard, there was a patient list we pulled for them for 6 months. So they then had to do it themselves as part of the sustainment phase. Another supervisor noted related to the patient list, I'm thinking I want to use her, program analyst, to be able to pull the reports because she's been pulling some other VASH related reports and things and it has been helpful. So that one person did end up getting a program analyst who was able to pull these monthly. And then the last really meaningful quote that came about in our sustainment phase interview was from a social worker. She said, one of our vets was working in a shelter and it was nighttime. And he was watching a video of the outside parking lot area when he saw a shelter person go down. He went outside to respond and he went and got his Narcan and revived the guy. And this is why we do all that we do. We want, we don't see most of the time or hear most of the time all of these impactful moments, but we want to make sure individuals who are at risk for opioid overdose are getting what they need. So on that note, with a lot of formative evaluation, I'm just checking the time, information, and especially at the pre-implementation phase is when we really use that data to shape our implementation approach. We coalesced, and we already had these planned strategies, although we slightly refined them thanks to the formative evaluation findings. We had the core implementation strategies across the sites of conducting educational meetings, distributing educational materials, auditing their performance and providing them this feedback about their performance at the site level. We had to create new clinical teams. Case managers or social work teams were assigned a prescriber. That was also a really big finding that I had not anticipated in our implementation approach. I did not know that even if a team had a prescriber, they had a prescriber for specific roles and they did not want to expand it to naloxone. So most of the time when we created these new clinical teams, there was a local pharmacist or two that agreed and they recognized this importance. And in the VA, pharmacists are much more a part of the team structure than for outside VA. Or it was a physician, but most of the time it was a pharmacist. We also had to change the electronic health record system. We had to make sure they got trained on the note template. There was a new note template for them to use to note that the veteran declined, accepted the naloxone, and it was at least offered it. And then for various reasons, we had to provide local technical assistance sometimes, whether it was the note template or using how to identify eligible patients. I ended up leading all of the implementation, which I'm hoping to not have to do in the future. That is a persistent challenge in implementation science, is to find the right practitioners for implementation while being able to keep your scientific hat on and do all your science. So it was quite a lot for me. It was less than other work I have done to implement interdisciplinary complex pain clinics because the format ended up being pretty straightforward. It was monthly meetings, an hour or less, using MS Teams with each VA's sites had VASH teams for 6 months. Sometimes we would have 20 on a call based on the site, how big it was. Sometimes we'd have 80. So we recorded all of the sessions and stored them on intranet SharePoint for them to view. That's also where we stored all the educational materials and resources. And just one site, the one site where I had the Board of Social Work issue met for 8 months. They still really had 6 months of implementation, but because they stalled out for the first 2 months, I just extended them to make sure the potency of the implementation approach was sustained. The reason I should have noted this, or I should note it now, because we were gathering performance, we were auditing their performance and looking at it. I intervened with the site after about 2 months. I was looking at their data and I said, they're not doing anything. They're not doing anything at all. So I was able to talk to the boss's boss and that leader who ended up being a new leader. And so people weren't talking to her and she was hesitant to bring things up to me. And it was by the use of auditing of their performance and auditing their performance that I was able to actually see that they weren't doing things and intervene. So there's other reasons to do that, even if it's not one of your implementation strategies. It's nice to monitor that, okay, is this having some impact that we're hoping it will have? Um, all right, next, I'm going to give you, this is an example of what we did for audit and feedback. And this is also where I'm going to describe why we moved away from a stepped wedge, moving from a low intensity to a high intensity. So this bar graph, this is one of our phase 1 sites. And if you look just before this dotted line where it says implementation period at the top, you can see 100 in blue and 429 in orange, and this 19%. And so this is the pre-implementation phase. So just before implementation starts, it shows that only 19% of HUD-VASH veterans who needed naloxone, who were at risk of an opioid overdose, received it. And then this implementation site is unlike any other. By the end of implementation, 72% of their HUD-VASH veterans were offered OEND. So that's just 6 months. This site was quite exceptional. They had a really established leader who could get her teams to do a lot. And it surpassed any expectations I had. It also meant that because I was convinced we were going to have to pivot to a high implementation strategy approach before when we were planning this trial, just based on all of my other experience, it just blew us out of the water. There was no need to pivot to a high intensity implementation approach with such a response. And also our partners in the VA, because a lot of what we do is quality improvement, and we have to be very sensitive to partners' needs. They didn't want us to continue to work with a site and do a trial. And so this is just one great example, but they would see each month essentially, here's where you're going and how you're doing. And so the blue is they got naloxone for a reason we identified. And then sometimes they got naloxone and we didn't know why, and that's the light blue. But this is also the number of individuals declined or pending an order. And I'm going to circle back to why is this so large? Um, Checking time. But before I do that, I'm going to hit on some preliminary findings. These are very high level, mostly. We've published the formative evaluation findings and are getting close to submitting some of our implementation outcome papers. But I just want to highlight this slide on the right. Essentially, there were 2,137 HUD-VASH veterans who were provided overdose education at our 6 implementation sites as a result or in alignment with our implementation. Of that number of veterans, 636 veterans received naloxone from the VA. And we trained at least 359 HUD-VASH social workers or case managers. They were trained in OEND at these 6 implementation sites. And these are our implementation sites. We implemented what's known as a small network, which is now reorging in the VA, at all these sites except for Central California, which is Fresno. And the varying shades refers to the overdose death rate per 100,000. So the darker the shade, the higher the death rate. And as you can see, these are all healthcare systems serving communities with moderate to high, because they're serving huge swaths. It's not just one healthcare system located right in San Francisco. They're serving veterans in all the outpatient clinics. As you know, there's if you know anything about the VA near you, the VA Northern California, Sacramento Martinez, it has a huge number of outpatient clinics and veterans that it serves. So just to give you some insight. So we completed at these 6 sites. Central California is actually part of another trial in the future. And then I just want to note that we conducted a fully adjusted discrete time survival model, which we had to adjust our analytic approach when we abandoned the step wedge. And what we found was a more than 2-fold increase in veterans receiving naloxone in the implementation phase relative to the pre-implementation phase. Also, that veterans receiving naloxone in the post-implementation phase remained higher compared to the pre-implementation phase, although it was slightly attenuated in the implementation phase. Okay. I'm trying to make sure I allow time for questions. So future work, this trial definitely motivated me to continue thinking about how to advance this work and where to go beyond just having an implementation playbook and working with partners, because we also learned a lot just from collecting all the multi-phase formative evaluation data, evaluating our outcomes. And we learned that determinants in the DSF's practice setting and ecological system impacted the generalizability of our tailored implementation approach. So I wasn't convinced that what we had developed was enough. I mean, in terms of or it was the right thing exactly. Do we even have to do 6 months of implementation, for example? So the other thing that one of the other things that really stuck out to me was, geez, these huge rates of declines. This is free. Why will you not take this free medication that will prevent an overdose from either someone near you or for you? And we saw around 50 to 70% decline rates, depending on the implementation site. as the trial progressed, it became available over the counter. That seems less relevant now as the VA is continuing to do free naloxone only by prescription in the VA. There was also during the trial this expansion of eligibility, which probably no one here who's not in the VA would know about. There was legislation, the National Defense Authorization Act, that passed that said we in HUD-VASH should also be serving people, veterans who have not been served to date, for their housing needs. So those would be those who have an other than honorable discharge or a bad conduct discharge from a special court martial. And that was great. So it expanded the number of individuals getting help, getting housing. Unfortunately, because they were not formally, and I don't know the exact term, enrolled in VA healthcare, they were not allowed to receive naloxone. So our denominator grew across the different later phases of implementation, but we were not, despite checking every 6 months, there was no policy, no policy is probably the best way to say it, to say that was allowed. So they did not get naloxone, and there are a growing number of individuals served by HUD-VASH. So what that told me was there's also an increased need to work with local community resources outside of VA. So the declines, the change in who is being seen in HUD-VASH for housing who can't get naloxone, and also was also informed by a phase 3 site where with large rates of decline for a free prescription from VA, a pharmacist got naloxone elsewhere and would give it to veterans, which is allowed. So it just really highlighted the importance of community partnerships for this work. And then lastly, as I mentioned before, a product for a lot of grants and implementation trials is having an implementation blueprint or a plan or a playbook. And then no one tests if these playbooks work. So in this next trial, we're testing if an implementation playbook is sufficient to get them increasing access and or adopting OEND. But before I get into that, I want to note, which I'm not going to have time to get into today, I want to note that because this was so interesting, the declines, and really not understanding and really not expecting such a large rate of declines for free medication, I was able to meet with a special veteran engagement panel that is sponsored by the VA's Pain Opioid Core, which facilitates research in pain and opioids. And it was in May 2025, and I was able to use this information to inform my implementation playbook for this later implementation trial. And it had 12 members present. It's 4 women veterans and 8 men veterans from different regions of the country, different service areas for the military. And it's a panel that's facilitated by an expert, and I'm able to be present. Before the panel takes place, they get these key questions that arrive in the mail and they ponder them, and then we come to the meeting and we go over these. So the key questions were, why would veterans seen in VA decline a free naloxone prescription from VA, particularly those served in the VA homeless program? What ideas do you have for a HUD-VASH case manager to increase the veteran's willingness to accept a free naloxone prescription? And what can be done to increase veterans' access to use of community resources for naloxone? And I will say some of it I expected, but some of it was really surprising to me, which is really highlighting the value, and I will continue to highlight this to anyone who listens, is really working with those with lived experience. Many of these individuals also had been homeless at some point in this special panel of harm reduction. So stigma was clear. If you have a prescription for naloxone, then others think you're actively using. I didn't really kind of thought, I naively thought, well, this is great. You're just giving naloxone to people who are in a high risk environment. They're going to use it on others. And I hadn't really thought like, oh, it's showing up in electronic health record and providers are seeing that they may be using. And actually, one veteran relayed a story that he got naloxone, then 3 of his providers, like primary care, mental health, sud care, all called him at different times to say, how are you doing? Are you using? And he felt that was exhausting. I mean, I thought that's great that they're checking in on you, but I can understand why it is exhausting. They really fear being labeled. They also, one vet noted, a lot of vets share about alcohol or different substances, but when someone mentions opioids, they would judge them. There's a fear of negative repercussions from providers inside and outside VA. All the judgment that comes with it, one veteran noted, from providers and from inside the VA as well as outside the VA, fear of repercussions, even though I'm not using, if I have this, it will hurt me in some way. Some noted if there is a veteran on probation or parole, which many HUD-VASH veterans can be, and the board finds out, it may have a negative impact because they think the veteran is using again. And then it varied across the veterans. Some said, oh, it's so easy for me just to go out and get this from my local community. Others said, I don't have vending machines. We don't have those. It's very hard to find free naloxone. For the follow-up question around the homeless services, one noted again the stigma piece. You're already being judged for being homeless, and so you don't want to be looked at in a certain way by taking it. And then another one, and they agreed, there was consensus. Like one, there's concerns about a watch list. Like you're an addict, and that's already a lot, and you're trying to get benefits. Like they may be taken away if they see you have an naloxone prescription. The other question or question two, like how should a head bash case manager approach a veteran to increase the willingness to accept it? They said really providers should focus on safety and letting veterans know it's available if they want it. Educate them on the ins and outs of naloxone and keep having the conversations over time, which I think is hard for many clinicians to bring this up at the right time or continue to bring it up at a good pace. I also didn't, well, one of these I didn't really know. Ask about the rumors they may have heard. So naloxone used to be primarily an injectable medication. Now this nasal spray is very easy to use. So, but ask them about what they've heard. Many of them don't want to use an injectable or have an injectable or try to figure out how to use, the injectable, but they're not going to have to do that because it's a nasal spray. And then one veteran said something that really resonated with everyone, which is frame it as safe, simple, and heroic, and to help a veteran struggling with addiction. Um, and then one veteran suggested providers saying to a veteran, you're doing amazing things in your life and community. Would you be willing to take Narcan for someone else that is struggling? And then lastly, and I'm almost done, key question three, what can be done to increase veterans' access to use of community resources, which, by the way, was one of the things we provided the teams with, which is I provided them with a list of local community resources, but they didn't seem to really use them. And that can be everything from community-based rehab center, methadone clinics, because those are places veterans can get naloxone. Make sure you train the social workers, which I did, on the community resources, but I don't think they shared them with veterans. But bottom line was educate everybody, which I don't think has also been done as much. And before I take questions, I really just want to acknowledge how many individuals in this huge team that was needed. We have multiple partners. We have the Homeless Programs Office in VA, including the offshoot of HUD-VASH. We also work with the local network homeless coordinators who are phenomenal. They do amazing work every day. Pharmacy Benefits Management is an amazing program in our group. We work nationally with them and with a local network, and we also work with the Office of Mental Health. And then my project team members from past and present are listed. And I also want to, again, shout out to the Pain Opioid Core Overdose Prevention Veteran Engagement Panel for helping shape some of the information going into the implementation playbook. And I should note that this work was funded by the VA Quality Enhancement Research Initiative. And the title of our implementation science center was Bridging the Care Continuum for Vulnerable Veterans Across VA and Community Care. And from there, I will stop sharing and take questions. Ooh, don't I have like 10 minutes almost? Yeah. Is there stuff?
Yeah, you do. I wanted to jump into the question before I switch to
Okay.
audio for a minute. And please, others, Amanda wanted them at the end, but you can still enter them in the chat and raise your hands, and we can call on you. So detailed and thoughtful, Amanda, and just like I really loved also how you showcase the way that the partnerships really change the work. I love that pre-implementation phase and sort of the real examples of what changed from it. I hope others can see. It took time, but you planned it, and it wasn't like you didn't get the project done within the 3. I think sometimes people think, oh, that'll slow us down so much.
Oh, yeah, no, it's only sped it up
and
even.
how, yeah. So I just wanted to, so actually I see 2 people with their hands raised. I just wanted to see one comment for you about the methods. It's such a big change in your numbers, but a hazard ratio or a relative risk, I can't remember what it was only 2.5 or something higher. I was expecting it to be like 20 times higher in the proportion, and that's really just because of the adjustments and sort of the stepped wedge rollout of your design. But still, obviously, it's a very significant increase. But the proportion, I love that you showed it both as proportions and as the ratios. Because I think that really gives the flavor of it. Sometimes we reduce ourselves to one number, and I actually think it showed it much better to show it. That bar chart was just so impressive. So It's more a comment, and just didn't know if you had any methodological sort of nerdy things to say before we answer the real questions from Anisha and William.
Oh, and and like I said, we had to abandon the step wedge because it was such a huge response to the low intensity. I was just blown
Yeah.
away. If only I could do that for everything. Um, and yeah, and I should note the audit and feedback. I didn't mention this, but we spent so there's a whole literature on audit and feedback and how to do it well. We refined our audit and feedback approach, how we displayed the data. That was only one component. I used to combine like graphic and textual description, but I also like that one because I can highlight what we did for part of our audit and feedback and with the proportions, and then also mention why we're not doing a step wedge. But they loved those graphs. The teams we'd met
Yeah.
with, they
I
were
really
like,
like it.
oh,
Yeah.
look at how we're doing, or oh, we're not doing much. When a site wasn't doing very well, I'd say, so I would actually alter it slightly and say, so your target might be to get up here before we meet next time, this percentage. And that's okay. Like every site moves at a different pace. So there's a lot of other data I could have shared too. I just tried to boil it down because this was a very complicated, it was
No,
a
I think it
5-year
was really
trial.
powerful.
So
Yeah.
it's
No, it's like a
still
really great
working.
example of a complex thing in one figure that can show sort of what it is. So I just wanted to compliment you
Thank you. Thanks, Courtney.
on that. Yeah. 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 And I think we can go Nisha and then William.
Okay, great. Hi, Anisha.
Hi, Amanda. Thanks for sharing about your work. I really appreciated how you talked about the flexibility you had to go through in combining the DSF and CFR because
Oh
I'm kind
yeah.
of at that stage where I like started with CFR and sometimes I feel like it's not enough, but it also has a lot of constructs. It's nice to see an example of what you actually have to do in practice. My question is actually about whether you use in the pre-implementation phase, if you use any quantitative measures of leadership readiness or like stability, because this is where I am
Yeah.
at in my work. And I know qualitatively you can tell if there's a lot of turnover, right? But did you use any scales or measures?
Okay, so really great question. Um, so there's a lot of measures out there quantitatively. In the past, I've looked into using the Orca. It's massive. I'm not sure when you break it down if it's going to be as reliable. And one of the developers, Christian Helfrich, who I know, and he was in the VA, he would also say it's like a beast. So I usually didn't do that. So I've tried the ORIC. I wouldn't say there's anything I've done just for leadership, is what I'm trying to say. It was like a reading, ORIC is readiness for implementation change. I used it in a implementation trial to set up complex pain addiction clinics. Couldn't, the qualitative data gave us so much more. And we also had planned to use the AIM, the FIM, and the IM, which look at acceptability and fees like those. Those are really short. And we were going to do it. And it just felt like we were getting enough in the qualitative data that we didn't say, hey, could you make sure you do these quick items? I'm always trying, especially when we're leading a trial, think about participant burden because we're about to get them to do all this extra work and change our workflows. So internally, we have an implementation and data core in our center, and we internally talked about it. But no, I have this constant push-pull with quantitative measures, which is ironic because until I went to postdoc, as I was funny, I'm a medical informatics postdoc at the VA in Stanford, and then I didn't do any qualitative. I was trained quantitatively, so I'm always like, let's get these quantitative measures out. And then I started to do qualitative, and I was like, oh, okay. First of all, I am still nervous about qualitative, but secondly, like this is getting such rich data that I feel like I'm also forming relationships. Sorry, this is my clinical health psychologist coming out. I'm forming relationships while doing these interviews, even if it's not me doing them. So there's a lot of like connection that we don't even talk about from an implementation perspective. We get from doing interviews that aren't just these pencil and paper surveys or Qualtrics surveys or REDCap surveys. Did I go over answering your question? Did I get at your question or did I over answer it?
Absolutely, yeah. And I also resonate a lot with what you share about this constant tension between quant and qualitative, because especially in implementation science, I find that a lot of the measures that are really well validated have a high participant burden. So, like pragmatically, I can't ask people
Struggle.
to do that. So like, so I appreciate hearing from you who's much farther
Yeah,
along.
maybe I'm giving up too quickly on the quant measures. We need to validate them, but I feel like I just want you to know that might be my bias, which is weird because my bias usually was I want as much quantitative as I can get.
Yeah,
I don't know.
thank you.
Yeah, sorry, William.
Yes. Thank you so much. This is such an incredible talk. I'm super
Okay.
passionate. Um, I graduated from the program a couple years back, and my background was in harm reduction, and so super. Yeah. So just super quick plug on to all the students there. If you want free Narcan, the counseling service, you can get that for free. Harm reduction services, which is a great nonprofit, which is where I did my practicum. They give out Narcan for free. And then finally, I work here at healthcare, the Department of Healthcare Access Information, and we have our CalRx program. And so that any
Ah, that's this. Okay.
yeah, so that's what I was plugging. And so you can get
Oh, less than $20. Can you get it delivered to your house?
yes, you can.
I love that. Actually, sorry, this is huge if you can get it delivered to your house, because going and then, some people fear just getting looked at funky from someone.
Yeah.
Yeah, go ahead. Sorry, you keep going.
No, absolutely. I mean, as someone who like led Narcan trainings and distributed Narcan, like just the level of like fear and stigma and bias to come up and get it, and so it does take a lot to get it. Just my question for you, real quick, is were you ever able to evaluate like a peer like network?
Oh,
Uh,
like using peers to
yeah,
disseminate. Yeah, so that, so glad you asked that.
peers
So
are the best. Yeah, yeah.
we do a lot of peer-based work in the VA, and actually in my center, there's always trials that are relying on peers to help engagement in mental health treatment. We had one project that was focused on reentry from prison, so having using peers to re-engage that veteran into the healthcare system.
Mhm.
I wanted to use peers because they are in HUD-VASH. But we found that because the case manager, the social worker, has so much constant interaction, relatively speaking, with the veterans. I mean, it depends on which stage they're at. Are they in their permanent, like, did they get at their voucher? Are they in their housing? That the peers were more infrequent.
Hmm.
But you're right, though, that they may be more receptive to peers than their social worker. At the same time, a lot of veterans, including the harm reduction panel, speak to how they want to hear from their clinician, their provider. But I am with you. The peers, I would consider trying to do a peer-based model if this were not so effective, aside from the declines. The declines are going to be a constant problem, and I'm not sure if the peers can circumvent that. But it is a really interesting question this year, because you may have heard we've had a lot of changes in the federal government, especially in the VA over the last year. We've had a lot of hiring challenges, and one of the trials we've just started relies on peers to help with engagement. These are to help with engaging the really high-risk veterans who have multimorbidity at high risk of adverse outcomes. But he is unable to start his trial because there are so many fewer peers than there were a year ago. So there's also a little more turnover in peers. So keeping them as part of a trial can be a little bit more challenging for understandable reasons. But I'm with you. I with I wish we could involve more peers. I brought that up when I was working with the sites for pre-implementation, and it just kept working out that, well, the case managers are going to see them. They're going to get the list. They're going to intervene. But how else we could integrate peers is important. Oh my gosh, we only have a minute left.
Yes, so I've got to jump in and thank everyone. First, I want to thank
Oh, yeah.
Will and Anisha for the excellent questions. Thank you. We really appreciate it. Dr. Midboe, thank you so much for sharing your work, the way you look at research, the way you see how it can help people. With like 30 seconds left, Dr. Midboe, what's the main take-home message for us today?
It is really that sometimes you can do a relatively light touch implementation approach and have the meaningful impact you would like to have. Like, oh, it's so challenging to figure this out. And also the discrete intervention of OEND. There's fentanyl chest strips, drug chest, like xylazine chest strips that I haven't mentioned because the evidence for them are more equivocal. It's a long story, but there's a lot that you can do in terms of harm reduction that's relatively light touch that won't take a lot of money and resources and make a big difference potentially.
Fantastic. Dr. Midboe, if we want to follow up with you, what's the best way to reach you?
Oh, well, I'm on the Midboe at health.ucdavis.edu, or I should have put that on the slide. I'm so sorry. Or amanda.midboe@va.gov. Either works. I'm
Super.
somewhere.
Thank you so much for sharing your work with us today. Thank you, everyone, for attending. We'll see you next week.
Great.
Bye-bye,
Take
and
care,
thank you.
everyone.